All right, so there was two terms, aerophagia, which is basically swallowing air, and then it was edentalism, which is the condition of toothlessness or losing teeth. So that could be partial or complete, but they're both edentalism. So it's just whether you lose some teeth or you lose all of them, which is the reason why I talk about most Southerners will one toothache, they'll pull them all out. I can't remember if there was another term. For some reason, I seem to believe there was, but I'm going to go back to, I'm going to start the PowerPoints. I'm going to share my screen, and I'm going to pull up the PowerPoint that we had in lecture. So I believe this is where we were. Come on, there we go. Let me go back. So that was this question here, the aerophagia and the edentalism. So that's why I addressed those. So in older patients, they do have more loss of teeth, which means they will have to get dentures at some point. Well, I really should say their dentition. Then there were different reasons why we should not do tube feeds on patients. So we covered the different types. These are, reasons for delayed gastric emptying, whether they have surgery, trauma, head injury, etc. So that was there. Potential complications, infection, aspiration, the tube can clog. And I think this is where somebody talked about, can we put soda down the tube? The answer to that is no, according to Lippincott, which is what I said already. We usually flush it with fluid, which is water or saline, to actually unclog the tube. There was one question about refeeding syndrome. So did you get a chance to look at the refeeding syndrome?
No, I did not.
So with refeeding, what happens is the fluid and the electrolytes, they shift, or there is a shift in the fluid and electrolytes. And that usually happens after someone has starved themselves for a long period of time, or they've been malnourished for a long period of time. So your anorexic nervosa patients, cancer patients, they have a shift in their nutrition, because usually after chemo, they don't eat as much. Chronic alcoholism, most alcoholics, they drink more than what they eat. And if someone has just massively lost weight, so this can cause a shift in a person who has been without nutrients for 7 or more days. So when starvation occurs and the body is without carbohydrates, and we need that for sugar, so we can't convert glycogen to glucose, so then the body starts using our protein as a source of food. So when the carbohydrates are reintroduced, then the body's reaction to the glucose with the shifts in electrolytes. So that's why it happens. So it's like when people go on these binges, I'm going to starve myself for 7 days. I'm just going to drink water. Then by the time they actually eat something, then the body is like, we haven't had food in all this time. And so now all our electrolytes don't perform the way they should. And we end up with electrolyte imbalances. So we want to get a history on our patients. We want to check our albumin and our pre-albumin levels, our potassium levels, our calcium levels, our mag levels. Those are all the different things we want to look at. If the levels are abnormal, feedings are started at a very low level, so we don't just give them all the calories of what they need to have right at that particular time. So if you have a low albumin or low calcium, potassium, then we're going to slowly introduce foods so we don't cause more shifts. Does that make sense?
Mm-hmm.
So we'll graduate them until full feedings are available or they are able to tolerate. So we don't really do nursing diagnoses, but we do focus more on an NCLEX. They have kind of put in a freeze, or they have decided to halt nursing diagnoses until they decide how they're going to handle that between the US and Canada. But you still see people looking at risk for fluid and electrolytes and all that kind of thing. We usually focus on the priority patient problem. So, if we're looking at fluid and electrolytes, then basically it would be a fluid and electrolyte issue. Does that make sense? Mm-hmm. Or an elimination issue or a nutrition issue. We won't necessarily say it's imbalanced nutrition. Do you understand what I'm saying?
Yeah, it does.
Okay. All right. So looking at malabsorption, what are some causes of malabsorption?
you call this? You can have,
So this would have been what you would have worked on, you know, before lecture, before you came.
yeah, I worked on it. Malabsorption, you could have some digestive enzymes like pancreatic problems, maybe pancreatitis, where you have put out the
Right. So
pancreas doesn't.
right. So all of these things here, the celiacs, HIV, pancreatic cancer, bariatric surgery, all of those are causes of malabsorption. There we go. So here we have, you know, several different pieces are working. So the mucosa and the small intestines, usually that absorbs our nutrients, right? So when we have malabsorption, then that mucosa fails to absorb or normally digest single or multiple nutrients effectively. So our amino acids, our fats, our sugars, or our vitamins, these will all have an impairment as it enters into the GI tract. Usually we have inadequate movement of the nutrients because they're not absorbed from the small intestines into the bloodstream or into the lymphatic system. So those are some causes as to why we end up with malabsorption syndrome. Lactose deficiency, this is usually because of there's a deficiency in the disaccharide. So in the intestine enzymes, the lactase it's an intestinal enzyme, and that causes, or that splits, and it's not as absorbable. It's not in an absorbable form. So most people end up with gases, which is what I talked about earlier. But there's a lot of different syndromes. So I would kind of understand what types of syndromes bring on malabsorption.
Okay.
Some of the primary bowel diseases that are associated with malabsorption would be an overgrowth of bacteria because things have sat in the bowel tract for so long. So that's why I talked about how often you poo. A bowel resection, celiac disease, all of those would be reasons why. Let me move the slide, wrong way, to the next section. So here the villi damage when you're looking at celiac disease, so your absorption will not occur. From a small bowel obstruction, or if you have decreased blood flow, you know, you can have giardia, which is a bacterial infection of the GI tract. You can have a fistula, which we talked about, where things can cross over. So you have two structures that have now blended together to become one. So a gastrectomy, bypass surgery, all of those are things that can happen. Complications related to malabsorption, so things like calcium won't be absorbed, so it will set the person up for what? What kind of condition?
Osteoporosis.
Osteoporosis and or fractures. Anemias is another complication of malabsorption because of blood flow not being able to get to where it needs to be. Blood disorders, so you have malabsorption and you're going to have issues with the liver because that's where our blood clotting factors are. Nutritional deficiencies in vitamins, so like B12, those will be affected, all your B vitamins. They won't be able to be absorbed. You'll have gallbladder issues that can develop. You can end up with tetany. You know what tetany is, which is the twitching of. Okay, so they can end up with that. So things we want to ask about is they have watery diarrhea. That's usually the most common form, sign and symptom that you'll see. Steatorrhea, which is that pale, bulky, malodorous stool. A lot of gas and bloating, hair loss, dry hair, dry skin. Those are things that we would actually see or have a history of. Then we'd ask them about weight loss and belly distension because if they're bloated, then their belly's going to be kind of big, right?
Yes.
All right. Then we're going to look for signs and symptoms of electrolyte imbalances, and we have two different signs. One is the Chvestek sign, and the other one is the Trousseau sign. What's the difference between the two?
The Chvestek isn't the one that you touch the face and the face twitches, and then the Trousseau, if you touch the what you call it, if you put a blood pressure cuff or something like that, and then if you put it too high, then their hand is gonna twitch.
Okay, I can barely hear you. And
Like
it's
with the Trissan, if you put a blood
trousseau.
pressure, yeah, if you put a blood pressure cuff, and then you inflate it all the way up, the hand is gonna twitch, and then if you put with the positive charge of oxy, it's when you tap the face, and the face is gonna twitch.
Right. So one, we have nerve excitability because of their calcium levels being too low.
Hmm.
So because their calcium levels are too low, then we do have excitability of the nerves or hyperexcitability. So it is with trousseaus, and if you pump up the arm with a blood pressure cuff, then you'll start noticing some twitching. So that is true. So yeah, I talked about B12 anemia. So folic acid, that's another one. Iron deficiency. So if they're not getting enough iron in their foods, like green leafy vegetables and things like that, because they're not, malabsorption. Other things that could play a role would be muscle cramps, bleeding, and iron level. These are the different tests that I said we would need to check for. So albumin, the electrolytes, PTT, looking for the prolonged PTT. That's because they have a decrease in vitamin K. So all of these are the ones we talked about in lecture. Vital signs that that should be part of our routine: pain assessment, belly assessment, basically a patient assessment. Oops, my fingers moving too fast. So we talked about gallstones can be a problem, kidney stones can be a problem, osteoporosis. These are complications. And how we're going to treat it is treat the primary disease. So if it's celiacs, then we're going to talk to them about, keeping wheat and things out of their diet, right? Give me some other food choices.
Celiac?
Mm-hmm.
Maybe rye toast or something like that. I've seen so many questions about the rye toast.
Oh, you're talking about rye toast, as long as it doesn't have
Yeah,
wheat.
yeah. Like, are you saying like food we're supposed to avoid or food we're supposed to
No,
eat?
foods that they can eat. So we already know no protein, right? I
Okay.
mean, not protein. I'm sorry.
No
No wheat.
fiber.
No
Hmm.
wheat. So what can they have? Because everyone says, "Oh, we got to have a gluten-free diet." Well, what's a gluten-free diet?
Some that have, I mean, no, I guess grains. Well, I mean, you just restrict the grains, and then I guess more high protein. Maybe high protein. I'm not sure, to be honest.
Okay, I mean, I understand.
Both sides.
So they can have like fish, fruits and vegetables, rice and potatoes without additives, or things that don't contain gluten in it.
All right.
Okay. So beans and lentils, nuts and seeds, eggs. So there's different foods that they can have. Lactose free. Most people usually take some type of lactose intolerant agents before they have like cheese or dairy or anything like that. But for overall malabsorption, we want to try to give them a high calorie, high protein diet. So high cal, high protein. Other
High calorie,
supplements
high
would
protein.
be to replace the electrolytes that are deficient. So calcium, magnesium, iron, and your B vitamins. They may get B12 injections. Lactate for the lactose deficiency. TPN if they need it, if the malabsorption is severe. Antibiotics to decrease bacterial growth. And then corticosteroids if they're having any type, which is an anti-inflammatory. So they may receive that, like mesalamine. Let's see if there's anything else. Pretty much that would be it. So, checking skin turgor, making sure skin's, warm, dry, and intact, checking bowel sounds. So those would be the things that we want to test for before we give them anything. Make sure we do have some movement. Let's see if there's some other specifics that I wrote down. I think that's it for the malabsorption. All right. We can move on to other interventions. Okay, so we had that already. Record INOs. Age-related and infant GI system. So the difference is infants have minimal saliva. Adults are swallowing is not under voluntary control. So the infants have less stomach capacity. Peristalsis waves can reverse in infancy. So this is all that we're just talking about infant system. For diabetics, we should have them eat regularly scheduled meals, understand the food groups, inappropriate family tendencies and cultural patterns. And I kind of talked a little bit about that on Tuesday. So, understanding foods that convert to sugar very quickly, like your rices, your flour tortillas, your macaronis, those are things, your pastas, all of those things convert to sugar fast. Obviously, things like potato chips and candy, that would be also on that list. So they should have some nutrition and meal planning, increase their activity. The goal is to try to, have them more height and weight proportionate, control their glucose levels, check their blood pressures, normalize their lipid levels to prevent cardiovascular disease. So usually caloric distribution is currently higher in carbohydrates than in fats and proteins. CHO just means carbohydrates. They have a greatest effect on blood glucose because they digest more fast or more quickly, and that can convert them to sugar. So here are those, when you're looking at a healthy diet, how much fiber you should have in a day, how much calories from carbohydrates you should have in a day, how much calories from fat, calories from protein, and what your daily cholesterol levels should be. So that was, I talked about how many grams should you have. So all of that is available or should be also in your book. For a heart-healthy diet, this is the different types of fibers that you should receive, or different types of portions you should have per day. So 20 to 30 grams of fiber is needed, 50 to 60 from carbohydrates, 20% of your calories should be from monounsaturated fats, 10% from polysaturated fats, and less than 7% from saturated. 15% of your calories should come from protein, and then you should have less than 200 milligrams per day of cholesterol. Lipoproteins. So your LDLs is which your low density, or some people call them the lousy. You want that number to be low, less than 100. It is the primary transporter of your cholesterol and triglycerides. They collect in the blood vessel wall. Your HDL, which is high density lipoproteins, and they will actually transport to the liver and be excreted out. So we want that to be between 40 and 50. If it's higher, is that a good thing or a bad thing?
It's bad.
If your HDLs are higher, it's actually good.
Mm-mm.
So if your LDLs are higher than 100, that's actually bad.
Mm-mm.
So your triglycerides should be less than 150 because that transports fatty acids to the blood. So that actually increases your fat content, that can adhere to the vessel wall, and you don't want that. Your homocysteine, this damages the endothelial arterial lining, and this can cause clot formation, and it's been linked to cardiovascular disease. So the higher the homocysteine levels, the higher risk of coronary artery disease.
Mm.
Malnutrition, I'm going to come back to that one. We've already talked, well, no, we haven't talked about it. We're going to talk about it here in a minute. But when you get to a point, like if you have bulimia or anorexia nervosa, or someone's starving you to death, then they're going to start you on liquid calories in order to boost your calories. until your body is accustomed to having those types of vitamins and nutrients in the body system. So this is where we would look at parenteral nutrition. I couldn't get that out straight. So we look at parenteral nutrition to help increase the caloric intake and vitamins and nutrients that we need until we get the patient to a stable state where they can actually eat and hold on to the nutrition. Infant breast and bottle feeding. So it's ideally good to breastfeed, more nutritional, easier to digest for the baby, and it actually has maternal antibodies that you can pass on to the baby to help boost their immune system. Some people have difficulty with breast milk or breastfeeding, and that's because of latching. So basically, the mother's whole areola should be in the baby's mouth in order for the baby to not just be sucking on the nipples, and then the mother ends up with a mastitis. So as I spoke on Tuesday, then the only people that should be pooing every 5 to 7 days are those individuals that are breastfed. Everybody else should be going on a regular basis, minimum once a day. Usually the formula fed or the formulas like Similac and all of those, they actually have iron in it. They're iron fortified, but it has a lot of fat and calories, and those babies pee and poo all the time. Milk, when you're looking at cow's milk, you have whole, low-fat skim. They're not recommended unless they're over 12. Some folks have done goat's milk as an easier digestible form of milk. So it just really depends on what your cultural preferences are. Some people want to breastfeed, some people don't. So, those are options. But babies should not get milk before 12 or before a year. So let's talk about failure to thrive in pediatrics. In your pediatric patients, what would be some signs and symptoms that a baby may be failing to thrive?
Yeah. I just noticed their growth chart will be so low. Like they'll be the height and weight will be below their percentile.
Mm-hmm.
Yeah.
So usually they don't gain weight. They have a lack of weight gain. The general growth in an infant is low. They have this can also happen even if you're a child, so not just an infant. So the change in the growth rate of a child compared to previous growth patterns. So like it seemed like they were getting really, they were gaining weight and they were up on the chart, and then all of a sudden they just drop off. Depending on the situation, it can affect their cognitive development. Their developmental overall and social delays may also be, a reason why, or a reason why most people start to investigate whether this kid's being starved to death or not. So although the prognosis is generally good for weight gain, cognitive function is below normal in the 50% of children who suffer from failure to thrive. So that's the more significant piece when you're looking at failure to thrive babies or kiddos. Then they may lose 50% of their cognition related to that. So 25 to 60 will remain small for their age. So whatever their growth pattern was going to be, the growth has now been stunted. So it's also called faltering growth. So FALTERING, faltering growth is another term for failure to thrive. So there's usually a primary and a secondary cause, and usually they're saying the primary cause is more organic and the secondary is inorganic. The primary results from inadequate nutrition related to either a metabolism problem or just general lack of intake of the food. Secondary cause is usually an underlying disease or disorder. So that would be your inorganic. Emotional deprivation, they can end up with heart defects or diseases, lung defects or diseases. They can end up with gastroesophageal reflux, constipation, or food allergy. Metabolic disorders, endocrine disorders, chronic infection. They can have damage to the brain or to the central nervous system. They can have an exposure, or things that can cause it will be an exposure to an infection, parasite, or toxins, or just ineffective feeding techniques. So, how to feed the baby is important. Position of bottles, positions of the baby for nursing. All of those there's a reason why they talk about these techniques because they're important. Make sure the baby's not getting a bunch of air or having, aerophagia where they're swallowing a bunch of air. So risk factors, metabolic syndrome, prematurity, maybe they were exposed to, alcohol, so fetal alcohol syndrome, poor parenting skills. So there's a lot of different pieces that can go into failure to thrive. Questions so far?
None.
Okay. So other things that can happen is a delay in puberty. So those secondary characteristics may not necessarily display until much later. They can have permanent restrictive physical growth. They can have a compromised immune system, or they can end up dying depending on the situation. So some things we want to look at is, get a history, see what their social history, environmental history. Years ago, there was an 8-year-old girl who was placed in a closet, and she had been there for years. And when someone finally, called CPS on this family, and they found this girl in there, her hair was, she barely had any hair on her head. It was very stringy and straggly, and she was developmentally delayed. So she was 8, but she looked like she was 2 or 3 years old. It was terrible. So you want to look at some of those social factors, family relationships, how do they relate to the primary caregiver? How nurturing is the primary caregiver? Maybe it's a financial situation. So remember, I talked about when you're telling patients about eat healthy, maybe, their dollars don't stretch, which is the reason why places like McDonald's and Burger King and Wendy's and, Cane's and all these places can actually survive, because then they start offering dollar menu food so you can feed your whole family for $10. Who wouldn't do it? Look at the general health of the person. So how many hospitalizations may they have had? Any birth history that could be a reason why they're having failure to thrive or faltering growth. Any surgeries or accidents, any nutritional issues currently, cardiovascular problems, bowel problems, bladder problems. What's their BMI? Their cognition, has there been any changes? Do they know where they are now? Any family violence or maybe family substance abuse that could be a reason why the individual has not improved in growth or in cognition. So for an infant, we want to get the prenatal history as well to see if there's anything during that time period that may have played a role into them having failure to thrive. Also evaluate the mother-infant bond, because that will be important as well. So things you will see is that the child will be in the second percentile on the standard growth chart for sex and age, or 20% below their ideal weight and height. Reduced muscle mass, reduced strength, depression, decreased strength, regression in developmental milestones, so they won't be able to achieve them, or there'll be a delay in that. Poor hair texture, as I talked about this 8-year-old that looked like she was 2 or 3. There may be signs of physical abuse, eye abnormalities, facial deformities could also be a thing that we have to consider the reason why they're failing to thrive. And that would be more like your cleft palate or your cleft lip. So that would play a role. What type of lab studies do you think you should get?
Albumin, serum albumin.
Okay.
And, the CBC, BMP.
Yep, CBC, platelets, I'd get a SED rate to make sure this is not something inflammatory. UA, culture to see if there's any infections. Metabolic screening. Electrolytes to rule out renal tubular acidosis. So I do that. Maybe lead, make sure it's not lead poisoning. And believe it or not, even in current day time, there's still kiddos that are, being exposed to lead. So your protein, your albumin, your alk phos, your BUN, your creatinine, all of these can help detect abnormalities and how much protein they're taking in. Hemoglobin electrophoresis, so this will actually help identify if they have sickle cell. Thyroid function and growth hormone to help determine if there's maybe a thyroid disease as to why they're having, failure to thrive. A sweat test to rule out cystic fibrosis. stool cultures to rule out any type of GI infection or GI diseases. So a skeletal series, an MRI to or CT to make sure there's no congenital abnormalities in the brain, a bone scan so we could see if there's any, what the approximate bone growth rate is or if that's been slowed. An upper GI series of the small bowels to see if there's any structural abnormalities. So maybe there's something wrong in the smaller GI tract, preventing nutrients to be absorbed. A swallow study to make sure maybe, the kiddo can swallow. And then they may do a gastric emptying scan to see if there's issues with the gastric system dumping the food into the small intestine. So there's a lot of different things to look at. Early detection is key. So monitoring that weight, that's why those babies coming back regularly in that first 12 months is imperative, because if there is something, then the pediatrician should be able to identify that. So do we just want to start them out, if they're starving, hey, let's, give you a whole bunch of food, or we want to kind of gradually get that process rolling?
I think gradually.
Gradually. We're going to do a gradual advancing of a diet to prevent refeeding syndrome, which is that electrolyte shift that we talked about earlier, hypophosphatemia, hypokalemia, which is potassium. We're going to make sure the diet is adequate in protein and all of those electrolytes that are imbalanced, the magnesium, the calcium, the vitamin C and E, the iron. For infants, infant formula or breast milk with an additional food may be given. If they're adolescents or children, then they may have small, frequent meals with snacks throughout the day, which is what we're supposed to be doing anyway. Oral nutrition between meals, so some kind of low volume, high caloric drink or in puddings. They may require temporary tube feeds depending on what's going on. And staying away from empty calories. Give me some examples of empty calories.
Those are the simple ones that you were talking about, like candy.
Like what, babe?
You say the candy, maybe like a box.
Yep. Those foods high in sugar. So candy, sugar, those high fructose corn syrup drinks and foods, those are the things they're going to stay away from. So, and we're going to replace those with foods that are high in nutrition. There shouldn't be any activity restriction. If they need assistive devices, we can, look at that. But because of a lot of the protein loss, muscle mass loss in strength, they may end up doing maybe physical therapy and occupational therapy to help increase their strength and also help to increase their motor skills that they may have lost. So those fine motor skills like holding a pencil or holding a spoon and things of that nature. Multivitamins for sure with iron and zinc. Vitamin D supplement would be another one. So kids can usually get something like that polyvisol, which is have all of the vitamins. Repair and correct any underlying causes related to that, and basically continue to monitor their intake and output, their height and their weight, their BMI, and see if there's any other changes they may have, GI, cognitive, respiratory, neurologic. Those will all be the things to monitor. Any questions?
Nope.
You're like, nope. That's too funny. Let's see. Sometimes they may give them an appetite stimulant to, help increase food intake, but they're going to start very conservatively first before they start looking at appetite stimulants, because that may cause another problem. So what would be some discharge teaching going home for these kiddos?
I mean, if the problem was with maybe the way they feed the patient, you just teach the caregiver how to feed the baby, monitor for aspiration, create an environment that is conducive for the appetite, and whatever condition it is, teach them against ways to the nursing interventions for the specific disease that they might have.
Right. And you may have to offer the food multiple times before the kiddo may actually get around to accepting it. And multiple could
Mhm.
be 10 or 20 times in a day. You're offering the same thing before the kiddo feels comfortable, eating it.
Mhm.
Um, so those are things, the psychological aspect or the psychosocial aspect from a parent's position.
Mhm.
We're not going to punish them or try to push the food on them. If they don't take it, we're just going to keep trying to encourage them to eat things and
Mhm.
to find out what they like to eat and stay away from things that are not going to be nutritious or help their condition at that particular time. So those are all the different things we would be looking at related to when they go home. What can they afford the food? Maybe they couldn't afford the food. We don't know. So that will be things that we want to look into, and then get social worker or get a social worker involved so that they can come, and help them or assist them with food and how to get food, and maybe food pantries and things of that nature that
Mhm.
can help them, um, you know, have some nutrition in the home. So,
True.
all right. All right, so let's talk about GERD. What is GERD?
Gastroesophageal reflux
Got gastroesophageal reflux disease. And this
disease.
is where the stomach contents flow back into the esophagus. And this is usually related to some type of, to the lower esophageal sphincter being kind of weak. So it's a backwards flow of gastric contents back into the esophagus. So usually you have that cardiac sphincter, which is higher up, and then right as you get to the stomach, the LES, which is the lower esophageal sphincter, that usually have some type of dysfunction that allows acid from the stomach to flow back into the esophagus. So things like obesity, smoking, excessive alcohol intake, and most people are like, oh man, I have heartburn. That's the beginning process. So, and the one thing about that, with all that acid backwashing, as we talked about before, you can end up with varices, you can end up with esophagitis, you can end up with gastroesophageal cancer. So those are things that we have to be mindful of. A lot of coffee or caffeine consumption, carbonated beverages, stress, those things can introduce GERD. Predisposing factors are peptic ulcer disease, which we're going to talk about, obstructive sleep apnea, cystic fibrosis, that malabsorption component, cancer. These are all things that can lead to reflux. Others are scoliosis, poor esophageal sphincter tone, as we already talked about, which would be the LES. So, so when you eat foods, then it goes into the stomach. Your food acids and the enzymes will start the breakdown process, and then that LES, that lower esophageal sphincter, is either weak or damaged, which allows that food to fluctuate back into the esophagus. The cells that align the esophagus are not made to withstand that type of acidic environment, and they become very irritated. So sometimes people have random episodes, and then it goes away, and then sometimes people have more frequent episodes for which they have to seek like Pepcid or Zantac or something of that nature. So if it occurs more than 2 times a week on a regular basis, then you should be thinking that this is probably gastroesophageal reflux. Makes sense?
Yes.
All right. So usually we have an increase after pain, or increase in pain after meals, and it can radiate to the back or neck. Other things we have to consider is like a hiatal hernia, which is where the diaphragm is kind of weak, and it can cause the stomach above to herniate through. So therefore, now we have gastric acids and foods that pool inside and in close proximity to the lower esophageal sphincter, increasing the pressure. So it's kind of a hernia from that area. So usually from fat, greasy foods, so your barbecue, your McDonald's, if you're that person who likes to eat like the fat of the meat, so like if you have a steak and you like that really fatty portion, sometimes peppermints can cause the lower esophageal sphincter to become weak. Or you can have something called Barrett's esophagus, where the lining changes to match the cell lining in the intestines. So that will also set a person up for cancer.
Mm.
All right, so you get a question?
No.
Okay, so here the esophagus is squeezing the food, you know, as it goes down peristalsis, right? But then we could have impaired more motility or irregularity in the closing. So that could be another cause besides the lower esophageal sphincter where we end up with the backflow. Um, hmm. Other things we can see is delayed gastric emptying, like that could be an issue from your overeating, hiatal hernia, or your antihistamines or calcium channel blockers. Those things can actually, cause the lower esophageal sphincter to be weak from the pressure, or it could be a side effect of medications as to why we get that backflow. Esophageal mucosa lining. So if you have the lining that's inflamed, or if you have ulcers and it's eroding, or if you have esophagitis or chronic inflammation, then that can also cause GERD. Stomach and acid content, so that can also travel into the pharynx or into larynx and reflux backwards or reflux up. To get into the windpipe and cause like a pneumonia, that can happen. They can get into the windpipe. You can see increased signs and symptoms of asthma. You can end up with a hoarse voice or coughing. So those are things when acids enter into the wrong place. And just, kind of food for thought. Have you ever burped and then like all of a sudden your whole throat's on fire and you're like, oh my God, that's that hydrochloric acid that was in your stomach now in your throat.
Yes.
Lifestyle changes is how we should treat it. So there's a lot of modification, avoiding fatty foods, eating small, frequent meals, chewing gum after and between meals. When you're eating your meals, try not to drink as you're eating, because that also increases gas, and usually someone that goes down the wrong windpipe, or so to speak, or down the wrong pipe, and now you're hacking and now you're just causing more regurg. Usually if they have a belly surgery on the fundus, this is the fundus the fundus of the stomach. So that's placed around the lower part of the esophagus. So these are some things that they can do. A fundoplication is what it's called, to help decrease a person from having GERD. So that's kind of a treatment that they can use. Or they can do an endoscopic intervention at the lower esophageal sphincter or at the gastroesophageal sphincter to help minimize reflux. So other things we can do is monitor for respiratory changes like an increase in cough or voice changes when you're lying down. Pain is aggravated by heavy meal, foods that make the symptoms worse. So we want to make sure we're paying attention to that. All right, so avoid alcoholic beverages, carbonated drinks, avoid drinking fluids 3 hours before bedtime, and then don't eat and lay down. So you shouldn't do that. Small, frequent meals, avoid spicy foods, tomato products, because they're acidic. And here you want a patient that has high protein and low fat. So remember a couple slides back, we should have between 20 and 30 grams of protein. Oh no, that was fiber. How much protein were we supposed to have per day? Do you remember?
I think it said something about, I think 20, 30, I think.
No, I think that was, go back to it.
That was the percentage?
Heart healthy. So from protein, 15% is what we, of calories should come from protein.
Okay, 10 and 20, okay.
Let me go back to, there we go. Let's see. So lose weight. Don't lie down 2 to 3 hours after eating. Keep the head of the bed elevated 4 to 6 inches. Avoid tobacco, non-steroidals, and salicylated aspirin. Also avoid peppermints and spearmints. Stop smoking. So those will be things that can be done to help monitor or to help keep GERD in check. From a medication standpoint, what can we give from a medication standpoint?
Proton pumping, like omeprazole.
Okay, so what kind of medication is
Proton.
omeprazole, which is proton?
That's let me see. That's proton pump inhibitors.
That is a proton pump inhibitor. So it's
Yeah.
designed to decrease the acids and help the esophagus heal. A lot of times they will start off with a proton, not a proton, with an H2 blocker, a histamine 2 blocker, which blocks histamines. So therefore the parietal cells will decrease their hydrochloric acid production, and it also decrease the gastric acid in the in the stomach. So the two medications would be ranitidine or Zantac and Pepsid. So those would be your H2 blockers. Your PPI or your proton pump inhibitors is going to be your omeprazole. So anything prazole would be your proton pump inhibitors. Long-term therapy is, we can use it, but it does run the risk of bone fractures happening to the individual. So the medication attaches to the proton pump on the parietal cells and blocks the release of hydrogen. And the more hydrogen you have in your system, the more acidic you are. So if it's decreasing or blocking that release of hydrogen, then it means that the hydrochloric acid doesn't form as much or doesn't form at all. Therefore, there's a decreased mix of the hydrogen to the chloride to cause more acid into the abdominal cavity. Prokinetics will prevent the delayed gastric emptying by improving the lower esophageal sphincter pressure and peristalsis. So you may see bethnecanol or Reglan. Those would be your two drugs that you would see there. All right. Peptic ulcer disease. Here we have an erosion of the GI mucosa by the hydrochloric acid and pepsin. So we can have a duodenal peptic ulcer, gastric peptic ulcer, or it can just come from physiologic stress ulcers. So the ulcer forms in the upper GI tract that affects the stomach, which is your gastric part, the duodenum, or the lower part of the esophagus. So because the gastric acids and pepsin break down the protective layer of the stomach lining, then we have an increase in stomach acid because we've lost that defense mechanism of the stomach, and then we have erosion that occurs. So medications like ibuprofen, aspirin, indomethacin, all of those are potentials to cause peptic ulcer disease. So we pretty much know what our stomach layers are, the mucosa layer, the submucosa layer, and what happens within those layers, right?
Yeah.
Okay, so just kind of a review. The mucosa layer is the top layer, which releases the mucus, rich in bicarbonate, that gives the stomach that protective layer or lining from the acids in the gastric pits. So in there we have the parietal cells, and what do the parietal cells release or secrete?
Yeah.
Just talk about it. The parietal cells, they release hydrochloric acid.
Hydrochloric acid. Okay.
Chief cells release the pepsinogen, and G, like in go, G cells release gastrin. Okay. The submucosa is the muscularis externa, which contains connective tissue, nerve endings, and vessels. And there's 3 layers of the muscles that's used to facilitate peristalsis, to push the food down. Then we also have the serosa. So we have mucosa, the submucosa, and then we have the serosa. So that's the outer layer that connects to the organ. So a lot of times when you have someone with PUD, then they're going to have indigestion that gets worse. It's a dull pain, and sometimes it could be bleeding involved. It could erode all the way through, and now you have a perforation in the stomach wall. So they could have Zollinger Edison's, where it's related to a tumor that oversecretes gastrin. So now that could be from smoking, Those are some causes that can lead to that. So in the stomach, its job is basically to liquefy the food, a lot of churning, a lot of mixing so that the nutrients can be absorbed into, as it goes into the duodenum. And then remember that there's bile that's released there to help break down fat. Okay. Key players was going to be the bicarbonate, which kind of coats the stomach lining. And then our prostaglandins, they regulate the perfusion to the stomach, and it regulates the mucus to release the bicarb. And it controls how much acid is going to be secreted by the parietal cells. So we don't want to have a toxic system where the hydrochloric acid is just, continually to be made. The pepsin via the chief cells, they can, that can work together to digest the food. But if we have a lot of acid there, then that's going to be that's usually the biggest villain of peptic ulcer disease, which is relates to or comes from H. pylori. So H. pylori is a bacterial, or is a bacteria that's spiral shaped that invades the mucosa, which starts the erosion to break down the ammonia and CO2 to neutralize the acid and break down the mucosa. So that whole H. pylori, the bacteria that relates or results in peptic ulcer disease, or this is another cause, that will now require antibiotics to get rid of, as well as an H2 blocker or potentially a PPI, proton pump inhibitor. But 90% of peptic ulcer disease it happens in the duodenum, and 80% happens in the gastric area. So usually if you have a peptic ulcer, it's going to be in the duodenal area.
Are the symptoms different from the gastric and the duodenum?
No, what I'm saying is 90% of peptic ulcer disease occurs in the duodenum.
Okay.
80% is gastric.
Okay.
So when you're looking at ulcers in general, most of them are going to be duodenal driven.
So, but the symptoms, are they the same?
No.
For gastric?
No. When you have a gastric ulcer, usually you have, you start seeing symptoms 1 to 2 hours after eating. So when you have gastric, you see symptoms 1 to 2 hours after eating. The pain is dull. They may have weight loss or severe vomiting blood. It could be coffee ground or bright red. Okay. When you have duodenal, you usually see pain 3 to 4 hours after eating. So you may wake up in the middle of the night with pain, and you may have some type of gnawing pain versus severe pain. Does that make sense? Okay. Yeah. Their weight's more normal, but now their stools may be dark and tarry. So we usually diagnose with an EGD. What's an EGD?
That's an endogastro. It's like a tube that goes in. It's like a colonoscopy type of thing, but it's it goes in from.
It's an esophago-gastro-duodenoscopy.
Yeah.
So that's a long word. It is a lot of words. So they're basically going to put a tube down the esophagus, go into the stomach, and basically take a peek and see what's going on. Other things they can do is an upper GI series where they coat the stomach with barium, which is, we all know is nasty, or they could do a CT scan of the belly with contrast. So with H. pylori, they're going to try to get a stool test or a blood test for it. They used to do something called the breath test. It's the urea breath test. So basically, you ingest a urea tablet. If it's H. pylori positive, it'll break the urea down into ammonia and into CO2. So the breath samples are measuring the CO2. And what you do is you blow into this bag, and then they send this bag off to the lab. And then they wait after they give you this urea tablet, and then you blow back into the bag again. And then they send both bags off. So it's like the before and after. So they know what your baseline is, and then if there's been a change. Things
Okay.
that complications related to peptic ulcer disease would be a GI bleed, which would not be good.
Okay.
Okay, so GI bleed, as I said, we can erode all the way through and have a perforation, or we can end up with peritonitis because now we have gastric content spilling into the peritoneum. Bowel blockage can also happen, and we can increase the risk of GI cancers. So these are all the causes or risk factors related to peptic ulcer disease. And as you can see, hot, rough, spicy foods are not an issue. So burning pain that lasts minutes to hours, gastric is usually high epigastric pain, duodenal is usually mid-epigastric. The breath test I've already talked about, the stool samples, the serum samples, medications. To eliminate H. pylori, we're going to give them these antibiotics. And metronidazole is Flagyl. So we would give them Flagyl. We would give them omeprazole. We would give them other antibiotics would be clarithromycin, amoxicillin, or tetracycline. All of that's going to be physician driven. Okay. H2 blockers could be given. So Pepcid, Zantac, or we could give them antacids. So that could be Tums, that could be Mylanta. So any type of antacids would be Rolaids, prostaglandin analogs and proton pump inhibitors. We can also use those. We can do surgery, so they can have a vagotomy, a pyloroplasty, or a gastric resection. Those are all different types of things that can be done. So a vagotomy is where part of the vagus nerve is cut to prevent it from stimulating the gut to produce hydrochloric acid. With the pyloroplasty, they can open the pylorus, and if it's narrowed, then from scarring, then they can kind of make it bigger. And then we know what a gastric resection is. So various types to remove diseased portions. So that way it can prevent dumping syndrome. And what's dumping syndrome?
Isn't that the one, what you call this? It's almost like refeeding, almost.
Well, refeeding is the electrolyte imbalance, right? So it's like when you eat something, when you haven't eaten, then you try to eat, and then those carbs, your body don't know what to do with it, so it starts doing a whole, fluid and electrolyte shift. Here, the stomach can't regulate the movement of the food because it's missing sections, and it enters into the small intestines too quickly. So the food acts hypertonically, pulling water from the blood early. And if it's late, if it's rich in carbs, sugar, the pancreas releases insulin. So the refeeding and dumping is completely two different things.
Okay.
So things we need to do is vital signs, bowel assessment. So abdominal assessment, bowel sounds. When's the last time they pooed? Did they vomit? What did it look like? If they're having diarrhea, how many diarrheal stews did they have? Because now we're going to be worried about, dehydration. The onset of pain, is it 1 to 2 hours after eating, 3 to 4 hours after eating? Does food help or make it worse? Medications, do they take aspirin, NSAIDs, steroids, anticoagulants? Do they have a family history of H. pylori? Do they smoke? Do they drink? So all of those are going to be things to ask for your assessment portion. Lifestyle modifications would be, eat a balanced, bland diet. And bland is that rice, applesauce, toast. That'll be your bland diet. So, you won't be eating, things with a lot of spice or sauces or tomato sauce or things of that nature. How would you know if someone's having a GI bleed?
They have dark tarry stool most of the time.
So dark tarry stools or coffee ground emesis or bright red blood or emesis. So those are things we'd be looking for. Their skin may be pale. Their heart rate would be elevated. Their blood pressure could be low. Their H&H would be low. If they have a perforation, then they're going to have severe belly pain with vomiting. Their heart rate would be up, respiratory rate would be up. They may have a fever because now that's an infection process, right?
Mm-hmm.
If it's an obstruction, then they're going to be bloated, they're going to have belly pain, they're going to be vomiting. Dumping syndrome, they don't remove the food like it used to. So after gastric resection, secondary to peptic ulcer disease. So just kind of understand what happens in that process. So the stomach's not able to regulate the food better. The food doesn't digest, or the digested food enters into the small intestines too fast or too soon. And once the food enters the jejunum, it's like a hypertonic solution. So the water shifts from the blood out into the gut. And this can happen within 15 to 30 minutes after eating. So that's why they have early dumping.
Okay.
So the fluid shift can cause bowel distension, and it can increase its motility. The heart tries to compensate for the sudden shift, so that bloating, nausea, diarrhea, hypotension, syncope will be 30 minutes after eating. The patient's going to feel terrible. So that's how you tell if they have dumping syndrome. Or if it's late dumping syndrome, that'll be 3 hours after eating at least or more. The food enters in too quickly to the small intestines, that's rich in carbs and sugar, and it causes the pancreas to release insulin, but it's like a big bolus of insulin. And when they get that big bolus of insulin, then all of a sudden their blood sugar drops. So now they're sweaty, they're weak, they're dizzy, they're pale, cool, clammy. So that's how the two methodologies. So again, the small frequent meals versus 3 large meals. Don't lie down 30 minutes after eating. Don't drink fluids with meals, but you can drink it after eating. Avoid sugary foods and drinks, or very hot drinks, or very cold drinks, so extremes of drinks. Eat foods that is high in protein, high in fiber, but low in carbs. So for PUD, we want to do high fiber, high protein, low carbs. For ulcers, we don't want to give them foods that's going to irritate the lining. So if you're talking about, like GERD, we don't want to give them spicy foods or acidic foods. So citrus foods, juices, caffeine, chocolates, fried foods, we don't want to do that. So for those folks, if they have an ulcer only, not peptic ulcer, just general ulcer, then we want a low fiber food that's bland and easy to digest. So that'll be your white rices, your bananas, things that don't require a lot of digestion. Questions? So these are all the things that I talked about here. If you have somebody that are exhibiting signs and symptoms of shock, then we're going to do fluid replacements is what we're going to do. And like normal saline or lactated ringers, we're going to give them some medications to decrease the acid production. They will not eat. So they'll be NPO. They'll probably do an NG tube. And a saline lavage is basically going in, flushing it out, and then sucking it back out. So flushing the stomach and sucking it out. Perforations, usually they have a sudden, unrelenting abdominal pain. Their belly will be distended and rigid or tight, hard. Bowel sounds will be diminished or absent. So here they're going to need antibiotics. Is basically we have gastric contents in the peritoneum of the abdominal cavity. So they can perforate. So you can have a hole in the stomach that erodes, or have an ulcer that erodes all the way through. Let's see. So what two populations are affected by malabsorption?
Like, what is this?
Two populations that are affected by malabsorption.
Children, or like, I talking about races, or
Infants and elderly.
Okay.
Which of the following are major modifiable risk factors for coronary artery disease? And modifiable risk factors are things that people can change.
Okay. Serum lipids.
Uh-huh.
Metabolic syndrome.
Mm.
And homocysteine.
Okay, so you say A, D, and F.
Yeah, diabetes too,
So that's
y'all.
metabolic syndrome. Or a newly inserted NG tube can be used. What's your nursing action that you need to do? What did you say?
Get an X-ray.
Yes, get an X-ray. I'm sorry. I was
Yeah.
dazed for 2 seconds. Which statement by the patient with type 2 diabetes is accurate? A, B, C, or D? What was that?
D.
D? It's
Oh,
actually A.
it's
So if
A.
they're going to have alcohol, they need to have a meal or a snack because remember, most people won't eat if they're drinking.
Okay. They have a glass of
So a child has an NG tube after surgery for acute appendicitis. What is the purpose of the NG tube?
A.
Say it out loud. I can't hear you.
A.
Actually, D. So if acute appendicitis, basically they've taken out the appendix. So we've had stomach surgery. Usually there's a bunch of gas because they kind of blow, they put air in the stomach so they can see the organs better. So the NG tube will help to decompress the abdominal cavity. All right, so here we go. Percentage of daily calories for a healthy individual. You say A?
Because of that protein. Protein is 25.
You're like, I can barely hear you, baby.
A. Yeah,
Okay. So 50% carbohydrate, 25% protein, 25% from fat, and less than 10% from saturated fats. All right, so a complete nutritional assessment, including anthropometric measurements, is important for the patient who what?
D.
Say it again.
D.
A?
D. D. D as in dog.
Okay. Reports an unintentional weight loss of 10 to 20 pounds. I could barely hear you. It's like you
Sorry,
you sound like the I'm like, what are you saying?
my fault.
It's like I can't hear you. All right, so put these in order.
All right. A1 is C.
Okay.
2 is A.
Uh-huh.
And three is B.
Okay. There you go. When teaching parents about caring for a child with cystic fibrosis, the teaching should include what? So cystic fibrosis is a part of malabsorption.
Absorption. Okay, so I'll be D. D.
D as in David?
Yeah, D as in David. A. Oh. Okay.
Oh, it's A and B. High calorie, high protein.
All right.
Remember, it's malabsorption, so they're losing nutrients. Okay. And then an appropriate meal for a school-aged child with celiac disease. would be what?
A.
Okay. Baked chicken, corn on the cob, and strawberries. Because I remember earlier you talked about rye bread, and I said
Mm-hmm.
long as it doesn't have wheat.
Mm-hmm.
All right, let's see. Do you have any questions?
No, I'm good.
You're like, I'm done.
No, I'm good. I'm good, friend.
Yeah.
This was very helpful.
All right. So, um, I may start the class with some questions kind of as a review, but know what
Okay.
fats are soluble and what fats are
Okay.
not soluble.
Okay.
Um,
A.
ADEK,
ADEF. Yeah. Yeah.
ADEK. That's fat soluble. Everything else is water
Okay.
soluble.
All right.
Um, so yeah, I may start with some questions, but I'm going to look at some case studies that we can
Uh,
start
uh,
off with the metabolism stuff, and there's going to be some crossover
okay.
with there'll be some crossover with nutrition because we're going to be talking about diabetes, right?
Okay. Yeah.
And
Yeah.
we also
True.
have thermal regulation to cover as well. So,
Yeah.
but just
Hey,
some,
I
just
wanted to ask.
go
I
ahead.
wanted to ask. I wanted to ask also. You see this video being on YouTube. Just
Yeah,
in case some other people want to watch it.
right. That is true. I'll
Mm.
set up the page. It's going to take us a little bit to download. So
Okay.
I'm thinking by noon it should
Okay.
be. But it's just like I said, it's going to be DCCCD
Mm-hmm.
Bridge. That's going to be
Okay.
your YouTube page. Okay.
All right. All right.
Remember that your histamine blockers have the TIDINE, so the tidines. So
Mm-hmm.
ranitidine, famotidine. Your PPIs have your prazoles.
Dissolve.
So
Okay.
your pantoprazoles, your omeprazoles. So that will help you, even if you don't know the drug offhand. Then if you know some of the
This is
ending,
dissolve.
it'll kind of give you an idea of where they belong to and what they should do.
True.
Does that make sense?
True. Yeah.
All right, Miss Suzanne, I'm glad you
All
figured
right.
it out.
All
Uh,
right.
let's see, let me escape and stop sharing. So if you
All
don't have
righty.
any other questions, then I'm going to stop recording
All righty. Thank you.
and we'll see you Tuesday.
All right. Bye.
Okay, bye.